Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Hello everyone, I'm so glad you decided to join us for another episode of the Research Works podcast.
Yes, welcome back everyone, and welcome to any new listeners we might have out there today.
Welcome.
Thank you for joining us. Today we are going on a journey. It's quite new to the podcast and new to us, and to help us understand this new world of knowledge, we have the consummate guide in Daniel Navon. Welcome, Daniel.
Welcome.
Thanks so much for having me. I'm thrilled to be here.
Oh, thank you for joining us today. And today we're going to be talking with you, Daniel, about your invited review that was published in Developmental Medicine and Child Neurology in 2022. It's titled, How Do Genetic Tests Answer Questions About Neurodevelopmental Differences? A Sociological Take. But before we unpack this incredibly interesting and I imagine complex topic, we're going to tell our listeners a little bit more about you, Daniel, today. So Associate Professor Daniel Navon is from the Department of Sociology, University of California. His primary areas of research are the sociology of science and knowledge, comparative historical sociology, social theory, medical sociology, and qualitative methods. Daniel is also an author, having published his book Mobilizing Mutations, which looks at the way that genetics is reshaping medical classification and patient identity.
Oh, it's very cool.
Yeah, so
very,
cool.
Very different in all areas. It's very cool.
Yeah. As you can tell, we're a bit excited that we have you here to talk with us today, Daniel.
So many questions. I'm going to hold back.
Well, I'm excited to be here. Thanks so much again.
So, Daniel, that's kind of the formal getting to know you bit. On this podcast, we like to do more of an informal getting to know you in the form of an icebreaker question. So our icebreaker for today is, are you a technophobe or a futurist? Would you prefer the world before the internet or the brave new world we have emerging now of artificial intelligence? It's a big one.
It's a really big one.
That's a really tough one. It's not the most. Thought you were going to ask me what my favorite flavor of ice cream was.
Oh, we can do that if we have time. Yeah,
we weave that in. I'm sure there's
mint chocolate chip.
Okay, great.
It's tough. If we lived in the world before the internet, I wouldn't have to worry about bots writing my students' papers, but I also wouldn't be able to talk with you. So
yeah,
this is true.
It's great to be talking with you, and welcome. From yesterday here in California.
Yeah, I know, right? That I find is always very, very futuristic. I would be the same. Like, I love the idea of making sure that our work is our work. I feel like I've had a bit of a play with ChatGPT and I've asked it some questions, and it's pretty clever. I mean, it gets things wrong too. It depends what's on the internet. But man, you could fast your way through a whole lot of stuff, and you know, even just the AI generated photos and all that kind of thing. I feel like it's just all happening a bit too quick. You know, it's kind of just, it started and it's just taken off, and I'm not ready for it, and it's got me a little bit scared. So, though I get to talk to you through this platform and I absolutely love it, I just don't know where it's headed. So I'm a bit of a technophobe on that side. Yeah. And I just keep thinking of like Skynet and WALL-E. You know, like there's all things that have foretold what could happen.
So. I think if there's not a little bit of technophobe in all of us, something is missing, because it can get pretty scary.
Yeah,
definitely.
Yeah, that's true. That's true. What about
I'm
you,
with you on that. I sit firmly on the fence on this one. I think I'm very comfortable with the technology I know.
Yeah. No more.
And I suppose that it does extend to ChatGPT a little bit, because I did ask it to write my daughter a bedtime story story last night and it did a great job.
Wow.
Really?
Yeah. She had some very specific requirements about the bedtime story. So it had to have a unicorn and a donut and something else. I can't remember. But anyway, ChatGPT did a much better job than I could have of a 3-minute bedtime story on that.
Wow. Wow. That's
So-
very interesting. And there's
Yeah.
Bard that's out now, the Google's Bard that's come out.
Yeah.
My goodness.
I know. But yeah, I'd like it to
Brave
not get
new
out of
world.
control.
Brave New World.
Brave New World. I'll stick to bedtime stories on it, I think.
I like it. I like it. Well, I mean, I guess it kind of relates to technology in a way, what we're going to be talking about
Yeah.
today. So let me give you all a bit of an overview about, where we want to be able to ask questions around.
Let's do it.
So genetic testing can provide some compelling answers, especially when it comes to neurodevelopmental differences. But when we really delve into it, what is the genetic test supposed to tell us? When we ask the questions, what is this person's diagnosis? What problems and developmental differences is this person likely to experience? What is the best way to approach their development, treatment and care? And will they have a life worth living? So in this invited review, Daniel sets the scene that aims to unpack these questions by looking at the history behind them and the ways they are asked. This paper provides a sociological take on the way a clinical genetic test result can reshape our approach to neurodevelopmental differences. Very much like the question, it's kind of like it's both worlds. There's a lot there. There's a lot there, isn't there?
Yeah.
Mm.
Certainly a lot to consider. And as we alluded to earlier, Daniel, this area of genetic testing is a topic we haven't really discussed on the podcast before. I certainly would consider myself a novice when it comes to my knowledge and understanding in this space. So would you help us out with some basics to start off with?
Absolutely.
Great.
I'll do my best.
Thank
Okay.
you.
I'm not a geneticist though, so just the people should
I think
have that
that's
safety
good.
warning.
Okay, so I suppose, first of all, can you talk to us a bit about how genetic testing has evolved over the past few decades? Like, what does it involve, say, now compared to previously?
Yeah.
Sure. So, I mean, that's a big question. It's a really important question. Genetic testing really begins in proper genetic testing. We're really looking at what we would now call the genome in 1959, when researchers are first able to stain chromosomes and literally look at them under the microscope. So these are these 23 pairs of chromosomes that make up our genome. And that's when they were first able to look at them with enough clarity to start to find differences between what they called chromosome complements. So they found some people who had an extra copy of a chromosome or a missing copy of one. And that was the first time that a genetic test could be used to kind of explain what makes us different from one another. So the first example famously was finding that trisomy, or 3 copies of the 21st chromosome, causes what we now call Down syndrome. Right. It was called Mongolian idiocy at the time. And so that's over 60 years ago. From there, they started being able to look closely enough to find little pieces. Well, I say little, they'd still be millions of base pairs long, but smaller pieces of chromosomes that were deleted or duplicated or whatever. And from there, they moved on to being able to do tests to see if like a single gene was missing, eventually being able to look at the sequence of DNA, the A's, G's, and T's that make up the genes that code for proteins that ultimately make our organs and bodies. And then eventually, with the Human Genome Project, they began to be able to get a whole sort of snapshot of the entire genome, all 3 billion base pairs. Most whole genome sequencing isn't actually all 3 billion. It's kind of a poorly kept secret. But we've gone from just being able to look at whole duplications or deletions of chromosomes, right? So there's 46 in the sort of average, quote unquote, normal person, through to being able to look at single base pair changes in the 3 billion bits of DNA that make up the human genome. And there have been some really important changes in that time. It used to be that if a geneticist wanted to order a test, they had to suspect which gene or which part of a chromosome or maybe one of a few genes something was going on. Yeah. Whereas now they can get snapshots of the whole genome or even look at the entire genome. Wow. And so there's been a sort of enormous series of changes over the last 60 years, and really over the last couple of decades, we've seen really, really rapid developments as well. And of course, genetic testing can be used for all kinds of different things. Right? So if you think about it in terms of sort of the lifespan, two prospective parents can do carrier testing. So they can see if they both have the same risk that they could potentially pass on to their child if they inherited two copies, right? So the parents are normal, but the future child might be at risk.
Right.
Of course, we can look at the genome of a fetus, right, and make decisions based on that, all the way through to testing people for neurodevelopmental differences, all kinds of genetic disorders, but also things like ancestry, right? What we usually call race and ethnicity, even though it's important to make that distinction, or to sort of confirm who their parents are, or perhaps for forensic DNA to trace DNA found at a crime scene back to a potential perpetrator. And so there's a whole range of ways within medicine. I could talk a lot more about the different forms of medical genetic testing, but even beyond medicine, that we can use this technology to answer questions.
Yeah. And I think that's really important context, because often, I suppose, particularly in health research, we are focused on those first few examples that you talked about where, previously you might zero in on a particular chromosome, but now we have the ability to kind of map the whole genome, which is amazing. What you talked about in this paper, I suppose the lens that you applied to the conversation in your paper is a sociological one. And that's, as well as being a new area that we're talking about today in genetic testing, I think the sociological take is a new one for us as well. So can you just talk to us about what you mean by a sociological take on this conversation?
Sure. It's a tricky question, and it gets at a lot of things. But I think sometimes we tend to think of the genome, our genes, our DNA. It's what makes us who we are, and we tend to think of it as very powerful and very determinative, right? If you have something that's going to really give you a pretty clear future, and it is a very powerful technology. Yeah. But like many other kinds of medical testing, there's a lot of uncertainty. And there's also a lot of room for variation. And so one thing I really emphasize in my book is that in many cases, like if we go back to the 1960s, we can look at the same mutations, right? The same changes in our genes or our genome or chromosomes. And even though those stay the same, and presumably their basic kind of pathophysiological function stays the same, what we think about it, what we do with it, what it means to people can be absolutely transformed depending on all kinds of social factors, right? So where they are, right? What kind of family they're born into, whether there is a knowledge base, right? Research has been done on this mutation, whether there's a patient advocacy organization and a foundation and a community of people who sort of don't just do things like try to raise money for research, although that's very important. They facilitate research. By coming together, they notice things about each other that an isolated sort of case study would never pick up. And so even though the change in our genetics might be constant over this historical period, right, the last 60 years, even with the same mutation, what it means can be utterly transformed depending on all of these kind of social currents and forces swirling around it. And so that's a big part of what I mean. And then the other thing is, kind of for any given patient, if you take a genetic diagnosis into different kinds of settings, it might mean very different things, right? So it might mean a lot to a geneticist, depending on what it is. It might mean quite a lot to a cardiologist, but it probably, at least in most cases, won't mean much to like a special education teacher or even most psychiatrists or psychologists. And so it's important to always think about, what does this mean? Even when we think we have really firm knowledge about the genetics itself, and sometimes even some of the kind of proteins and physiological pathways and stuff like that. Even then, there's still a lot of scope for variation and uncertainty.
It's like taking a step back and its perspective and context, isn't it? It's just it's understanding all the layers associated with it.
Definitely,
I like it. It's good.
Yeah. And again, we tend to think of DNA as like the book of life.
Yeah.
It's the language in which God created man, as I think what Francis Collins said when the human genome was announced. And so we've built it up as this thing that kind of gives us very firm answers. And it can in some ways give us very firm answers, but it also leaves a lot up to us, right? And what we decide to do with it or do without even thinking.
Yeah.
Even if, as you're saying that, I'm thinking of all these questions about what it actually means.
Yeah.
And with all this knowledge.
And what it means to different people. Like I'm just thinking about your point, people like, Dana is a physio or physical therapist who sees a child. You're looking at the child as a whole person and you're focusing on, what their goals and aspirations are and you're creating a program to help support them to achieve that. And what comes out in a report about the genetic code doesn't really have much of a bearing on that, does it?
Not from an intervention perspective, because the overall goal is quality of life. And so that I understand that perspective, but then you go a little bit deeper, and you go from someone else's perspective, like you said, with the parent that might be going, well, we want to expand our family. Actually, that genetic testing is probably really much more important, and the specifics really are. So, they're really different perspectives.
Yeah.
I mean, there's a big debate in the genetics community, or not debate, just a lot of discussion about what it means for a genetic result to be actionable, right? And so, on one extreme, it points towards some kind of therapy or dietary change or something that can save someone's life, make them go from probably, quite profound disabilities and impairments or even death to being pretty much unaffected, right? That's one extreme. But then it gets kind of murkier and fuzzier as you move away from that extreme. And so does early intervention count as being actionable, right? Does recommending physical therapy before problems set in count as actionable? There's all kinds of debates about, or does sort of surveillance, right? Saying that maybe someone should go see a specialist every year to get checked up in case something develops. Does that count as being actionable? And so it's a big question, because we sometimes think, we probably shouldn't test, say, a baby for something unless it is going to tell us something we can do. And that's why the question of what it means to be actionable becomes so important. Sometimes it's quite clear. In other cases, it's really much, much, much trickier.
I guess leads really well to, one of the first questions you ask in this paper, which I've read many a time now, just, understand the flow and the thought of it. So the first question was, what is a person's diagnosis? It's kind of what you were just talking about then. Let's go into that a little bit more, because I find that really interesting. And, what would you say? What's in a person's diagnosis? Let's start there.
When they get a genetic test result?
Yeah.
I mean, it depends. It certainly, so a big issue in the field of neurodevelopmental differences, of kind of rare disorders more generally, is that families often go through what's called a diagnostic odyssey. So a child by the age of 4 or 5 or even younger might have a really kind of full medical chart with lots of different diagnoses. They might be psychiatric, they might be physical, clinical, lots of different things. And it's very, very it's stressful and heartbreaking for a lot of families, because it's clear there's probably some underlying cause that might help explain all of it and maybe help point towards something to do about it. And so you have these diagnoses, right? It's not like they haven't been given a diagnosis, but they've been lots and lots of different things. And sometimes a genetic test result seems to kind of end the diagnostic odyssey. And that's seen as one of the big kind of benefits. And so you have a diagnosis that explains the other things and actually makes them more like symptoms rather than like real diagnoses in their own right. But then the question is, okay, well, what can you do with that diagnosis, right? Where is it going to work as a diagnosis? Because again, most genetic disorders are very rare and they're not recognized even among most doctors, never mind among most psychologists or special education teachers or whatever. And so what it means to get that diagnosis is quite uncertain, right? It depends how much research has been done on it, which in turn depends on whether there's a patient movement. So if you get a diagnosis for a kid and it turns out that there's thousands of people all over the world who really identify with it, and families going to meetings and raising money and talking to each other and providing support and creating data repositories with their genetic information and children's medical, all of that allows us to really understand the diagnosis and sometimes to do a lot with it. In other instances, you might get a genetic test result that shows, this is probably why things are going wrong, but you're the first case we've ever seen. And so there's very little we can tell you, right? Or maybe there's a handful of people scattered around the world. And so there's an enormous range just based on things like that, right? And I don't want to go into there's a lot more to say about it. But the other thing I'll say, though, because it's a really important point that I don't want to leave out, when you get a genetic diagnosis, or when someone gets a genetic diagnosis, there's a big difference if they got it because they had the telltale signs of that condition versus if they got it on a screen, right? So either they got it maybe on a prenatal screen or a newborn screen, where for a lot of these conditions, we only know about them because pretty severely affected people came to a doctor's attention. They referred them to the geneticist, they did the testing. And so what we know about most genetic conditions is ridden by what's called ascertainment bias.
Right.
We only test the people with the telltale signs. And that means for people who get it but don't at least yet have the telltale signs, we always need to be aware that the diagnosis brings with it even more uncertainty. Because we know that for the most part, the people who are diagnosed, at least early on, are probably the tip of an iceberg. And what lies kind of beneath the surface is usually much, much more variable. And so it's important, I think, for all kinds of people who are, whether it's a parent, a doctor, another kind of caregiver, another kind of clinician, whatever it is, to always remember that a genetic diagnosis usually is not destiny. Right? There's usually a lot of scope for variation that will itself depend on all kinds of other things. There are cases where the outcome is going to probably be bad, right? The child probably won't survive early childhood. But in the vast majority of cases, there's a lot of uncertainty. And when I say uncertainty, I don't mean that we understand the range of the condition and we just don't know where you're going to fall. We don't even know the range of the condition because we've only tended to test people who are pretty severely affected. And so it's always important to keep that in mind and to try and have a sense of an open future, right? And that there's things that can be done. And there's just, many different possible outcomes, right? Especially if someone is, quote unquote, ascertained on something like a screen or because they have an affected sibling or something like that, right? Not because they have the telltale signs.
And are there guidelines in place for the kinds of supports that should be around a family when they go through this process of getting genetic testing? Like all of those issues that you've raised, it seems to me that whatever the outcome of the testing is, that family and whatever journey they end up going on as a result of what they find out require support around them. So, are there standards for that?
Yes, but not to provide that kind of robust support and guidance. So most of the time in most places, there's variation here. Genetic testing has to involve a genetic counselor. So this is genetic counselors are a really, really important piece of the puzzle of helping people make decisions about genetic testing and also helping them understand the results. But it can be as little as just the kind of disclosure, right? Where they can say, this is what was found, this is what we know, goodbye and good luck. Because there's an incredible shortage of genetic counselors, right? If there's anyone out there who wants to do work that combines research and clinical work and care and potentially patient advocacy and being at the cutting edge of exciting stuff, but also helping families, we need more genetic counselors. The U.S. has, we have 360 million whatever people. Genetic testing of all sorts is just going through the roof. And I think we have, I might be off on my numbers right now. I think things are changing. I think we have something in the region of 15 to 25 genetic counseling programs that usually have around 10 people graduate per year.
Oh, wow.
It's an extremely,
Yep.
very, very thin. And so there's licensing issues and all kinds of things that mean, when we think about, people getting results from newborn screening, people getting results from carrier testing, prenatal testing, cancer risk assessment, heart, all kinds of things.
Yes.
And a genetic counselor has to be involved for all of that.
Yes.
So some genetic counselors, despite all that, also manage to work with patient advocacy organizations, do really important research, but they're the bridge.
Yeah, sure.
Right? They're often the bridge between real people trying to understand, but also patient groups and families trying to work together with researchers to help us understand and do something about these conditions. And so genetic counselors end up being really key. Beyond that, if you get a diagnosis that has a robust patient advocacy group and a foundation, they will provide some support likely, but that's not always the case by a long shot.
Okay.
And here in the U.S., there's even issues about healthcare coverage.
Yeah, sure.
Right. Never mind the kind of more targeted support that someone might want as they start the journey of understanding what it means to have someone with a genetic diagnosis in the family.
So when you talked about, the screening that can happen versus, they've noticed symptoms and then you get tested as a result, I'm just thinking about screening from the perspective of, it sounds like it's possible to, well, does it exist? You normally go to a medical professional and say you want to screen, but is it possible to get screens? You're talking before about DNA testing and finding out maybe who your ancestors were. A lot of them can be sort of self-sought after kind of things. How detailed are they, and what can people figure out through that without even involving, I guess, a medical team and genetic counselors? Is that possible to do that?
So if you're we're thinking about sort of 23andMe, kind of what's called direct-to-consumer testing, where, you spit in a tube and you put it in the mail,
like
and you get these results back.
kind of stuff.
Yeah. So 23andMe they do both the ancestry stuff and some health stuff.
Yeah.
All of it should be taken with a huge mountain of salt, not just a grain of salt.
Yeah.
Right.
There's a lot of issues with it. There's a few things to say about that. First of all, I think it's important to point out the reason it's so cheap is because the business model is that they take your genetic data and sell it to researchers and pharmaceutical companies, right?
Yeah.
The reason you pay $100 or whatever is more to make it seem like it's a service to you, but that's not the business model. So just important to keep, you can opt out of that, but they don't make it super obvious. So just important to say that.
Yeah.
The health information it gives you is extremely limited. It's nothing like real clinical genetic testing. Now, if you have the resources, you can go and get a whole genome sequence and you can probably find an expert to interpret it for you. And an algorithm will do a bunch of the interpretation, but the last stages always have to involve, a human using their judgment and knowledge. Yeah. So some people can do it, but that's the kind of whole genome level snapshot. Every baby in the U.S. And Australia is screened for a handful of genetic disorders, usually without their parents even knowing about it in the first days of life. Yeah. Yeah. So we do have, and it's technically a biochemical screen, but it's for genetic disorders, and they followed up with genetic testing if there's a positive screen. And so we're all subject to genetic testing very early in life, right? 99% of people. But in terms of getting that kind of clinical grade genomic testing, you have to really seek it out if you don't have something that makes, your healthcare system or your insurer here in the U.S. want to pay for it, right? So there are these kind of boutique personalized medicine things for the wealthy where they pay to have their genome sequenced and have a geneticist sort of look at it all. Yeah. But so far that's not happening. I should say there's a big movement right now to move towards much broader genomic sequencing as part of newborn screening.
Okay.
England is really kind of paving the way on this. They're about to launch a major trial of it to see if they want to integrate it into their national healthcare system.
Wow.
The future here is very unopen, but it's watch this space.
Wow.
We might all be getting a lot more very early in life in the next 10 or so years.
That's so interesting.
It is.
Yeah.
It's a lot of things that come up from that. And I guess
it's a lot to take in.
It's a lot, yeah. And I think what you said earlier really prompted a thought where you kind of go, okay, if you do a screen and say you do find something, what does it mean? And I love how you said, you still got to give room for hope and growth still, because otherwise you could just be waiting and expecting the worst or preempting everything that you see and thinking there's something wrong when functionally it may never manifest, and you live this life not living to your fullest. Yeah. Like, that's a real thing, right?
Yeah.
Yeah, I mean, there's a number of reservations that people have about genetic testing, especially when it's not quote unquote indicated by something that makes you suspect a genetic problem.
Yeah.
Because you can spend a lot of time wondering and worrying, sometimes about risk. One thing that I've noticed a lot in a bunch of different areas of genetics in my research is that sometimes it's not even just about risk. You'll actually start going back and looking at things that seem normal to a regular doctor or psychiatrist, but that you then reinterpret as a kind of subtle effect of the genetic change.
Yeah, right.
And so sometimes it's not even as future-oriented as waiting. It's actually starting to reinterpret things in the present.
Yeah.
So there's a lot of ways in which knowing that can really change your outlook and your orientation to differences. And again, this isn't unique to genetics, right? If we did whole body MRIs on everyone, we'd find all kinds of stuff. Right? Some of which looks like it should be causing major problems. I know sometimes there are instances where they, on autopsy, find someone had, what looks like crippling atherosclerosis, and they were fine.
Yeah.
And so it's always important to not kind of fetishize genetics and think that DNA is destiny, because just like other kinds of genetic testing, there's a lot of scope for variation and uncertainty.
I think the other thing I think about as well when we talk about, broadening screening, screening more people for more things, there's a flow-on effect at a health system level as well, isn't there? If you're identifying more, like it's great if we're able to identify children early and get them into all the things that we know are positive for their development, like early intervention and having all those supports in place. But that's additional resourcing that we need to find.
Absolutely.
And that probably needs to happen before you start implementing things like that, so that the system can. And
it's resources that here in the U.S., especially because of our healthcare system, are very unevenly distributed. Some people can do that and some can't. I should say that the flip side that many people would point to is that sometimes there's some disorders where if you catch them early, you can do things that save an enormous amount of money over the lifespan, right? Or just the first several years of life. So exactly, and especially with gene therapies on the horizon and stuff, there are cases where it probably makes sense to do this, especially for people who have a quote unquote indication, right? They have the sign that indicates a genetic disorder, right? So it's a very tricky one. And I should point out too, most of what I'm talking about is testing for pretty rare disorders.
Right, of course.
Most people won't get what we would call like clinically significant or actionable results, right? Yeah. Quite a few people will, more than we thought, I think. But most people might get carrier results and things like that. Things like genetic testing for risk outside of some rare conditions that are associated with like cancer and heart disease and stuff, that stuff is really in its infancy. And I wouldn't want people coming away thinking everyone can go and get information that they could act on, even if it's uncertain. Most people won't get anything that's especially useful knowledge.
And that comes back to that question of what is in that diagnosis, or what is in that? What does it actually mean? What's actionable? Something I really wanted to ask you about, which I found really interesting in your paper, was the signs and symptoms or developmental differences that relate particularly to autism spectrum disorder and how that seems to appear in a raft of genetic conditions. Can you talk us through that? Because I think that's a very interesting point. You know, you often do talk about, you know, you do hear that, you know, they've got autism-like features or whatever it might be, that terminology comes up a fair bit. Can you talk us through through those points you're making in your paper?
Yes. I could take us through the end of the podcast on that.
Okay.
So there's a few things to say about that. So from the perspective of right now, there are hundreds of genetic changes or genetic disorders that are associated with autism, right? But in almost every case, many of the people with those disorders don't have autism. Some do, some don't. It might be 20%, it might be 80%, but in, I think, no instances is it 100%. At the same time, most people with autism, you can't find a genetic explanation, right? It's growing, it's pushing 50%, but it's still less than 50%. And so we have this very, very broad condition, right? It's broad clinically, like autism covers an enormous amount of what geneticists would call phenotypic range, but just a lot of people with different kinds of differences and disabilities and so on. But genetically, it's also very heterogeneous is the language, right? There's hundreds and hundreds of things associated with it. But one thing I've shown in my research is that probably wasn't always the case.
Right.
So autism started off as a very rare thing and a very specific thing with very kind of specific prescribed diagnostic criteria. And if we go back and look in time, we find all of these people with genetic mutations, right, that have been around for a long time. We've known about them for a long time. And throughout the 60s, 70s, 80s, even much of the 90s, those very same mutations were not associated with autism.
Right.
Because autism was still narrow enough that it didn't really overlap with those populations, people with those genetic changes. As autism got more and more kind of diffuse, right, as its diagnostic criteria broadened, it starts overlapping with these genetic conditions. And so we now think of autism as quintessentially a kind of neurogenetic disorder. Right? It's the most genetic because it has very high heritability estimates. But that's a result of these changes. And ironically, and again, I could talk about this for far too long, thinking about autism as a genetic condition helped to destigmatize it. Because we used to say autism was caused by bad parenting, primarily by quote unquote refrigerator mothers. And so the idea that it was genetic helped the patient movement really get going, and it helped drive its expansion. We got more aware of it. We got more aware of autistic differences. We started thinking of autism as this much more heterogeneous thing. And doing that, ironically, right, again, it was partly driven by the idea that it was genetic, made it big enough to bring all these genetic mutations, all these people with genetic disorders into the kind of autism category, into the autism umbrella. And so there's this, and this shows how kind of dynamic it is, right? Just knowing about a mutation doesn't tell you what the person has. And in fact, what you're going to say they have will change over time. Someone with Fragile X, someone with XYY syndrome, someone with all of these conditions, they wouldn't have had been diagnosed with autism in the 70s or 80s. And today they probably would, they very likely would be, or they'd be much, much more likely to be diagnosed with autism. So autism really helps us see how dynamic the world of genetics is, the way it shapes identities, but also how what it means to have a genetic mutation and what it means to have autism have been in this kind of dance together for a long time, shaping one another. I hope that makes sense. It's kind of, I know it's a little counterintuitive.
No, I think you've explained it beautifully.
So well,
my brain is playing catch up a bit, I think, like with like the enormity of it all. And it's really, I think.
But there's another point to make about the genetics of autism that be remiss not to make too. Sometimes when you have an autism diagnosis, but then someone gets a genetic diagnosis, it changes the way they think about autism. So Fragile X was like the most famous disorder associated with autism. And it's seen as a model for autism. Researchers try to use Fragile X to understand autism and develop autism drugs. And it hasn't quite worked yet, but there's a ton of work on this. But kids with Fragile X, they have a lot of autistic features, although, as I said, they mostly weren't diagnosed with autism a few decades ago.
Yeah.
But for example, they have an avoidance to eye contact, which is a kind of classic autistic feature. But in Fragile X, the thinking is it's because they're hyper aware of the other person and it's causing them anxiety. Whereas in quote unquote classic autism, it's because the thinking is it's because they're almost not aware or not interested in the other person. And so the same symptom gets turned into, in a way, the opposite. Hyper awareness of the other person versus the absence. And yet it's still autism, but the genetics changes the way you think about it. So it's important to keep in mind how having what's called syndromic autism, right? Autism where you think you know the genetic cause can actually mean something very different than what's called idiopathic autism or autism where we don't know the cause.
Yeah. And I think that's a really important distinction when you are potentially talking about people with autism-like features, which is the point that you made earlier. So there's, people who have autism, but then there's these people who have autism-like features. And that's kind of what we're talking about there, isn't it, with the idiopathic and that's, autism potentially. Or there's at least some overlap there.
There is. And I'm thinking about, back to the question before, in those instances, it would be so important for me as a clinician to know that, to know the difference, because you are approaching it in a very different way. And your language with the family, to make it consistent so it's not confusing, it needs to be along those lines too. So it's important to know those things. And
for a therapist, a psychiatrist to know that, or even a teacher.
How you set up the environment.
If a kid is in a setting where eye contact is going to be very disturbing for them, that's a huge thing to know.
Yeah. They're very contrasting. There's so much more to go into, and I'm just trying to sort of really figure out the place I want to go to next, which is sort of around, we sort of mentioned a little bit before, and it's kind of like gene therapies. Gene therapies are something that I have now noticed a lot in practice. There's more talk about it. It's there's a bit more urgency now. So, we're going to get this, I'm meeting families who are getting gene therapies. They're traveling all over the world for it, and I don't necessarily know what it is. And they come back and they go, okay, we need to do therapy to maximize this new gene now. The thing that was missing is now back. And there's a lot of hope associated with that, but a lot of uncertainty. And I feel like I'm playing catch up to what that actually means. And it kind of this whole area of people talking about like precision medicine, we're being very precise and we're treating that thing that's missing. Talk to us a little bit about that. Like where are we at with gene therapies with relation to neurodevelopmental differences? Like where's the state of the evidence there?
It's a great question. I think we're all playing catch up with this because the changes have been so rapid. So I started teaching when I got to UCSD in 2015. I started teaching a genetics and society class, and in 2015, I could say gene therapy is it's been 10 years away for forever, right? It's very futuristic, and it's probably don't have to talk about it in too much detail. But because of this new technology, these CRISPR editing systems, CRISPR-Cas9 and other editing systems, where basically we discovered these populations of bacteria had developed a kind of defense mechanism against viruses that meant they would cut their genome in very specific ways. We basically bootstrapped that and figured out how to use it to edit human DNA, right? So it was something we kind of discovered in nature and then figured out how to hijack.
Wow.
But it's revolutionary. It really is. And so, the sort of skeptics like me are having to say, well, the future is coming.
Right.
There are many dozens, maybe hundreds of true gene therapies in development. There's a lot of questions, if you cause it to make this change in one piece of the genome, might it make other changes that you aren't aware of? It's called mutagenesis that could cause cancer and all kinds of things. There's a lot to worry about. There's a lot to be worked through.
Yes.
But there are now true gene editing therapies for sickle cell here, and a number of other conditions coming through. They cost $2 or $3 million a pop.
Yeah.
Whoa.
But for some conditions, when you compare that to the lifetime of challenges and other kinds of treatments, it's not crazy to spend maybe not that much, but a lot of money. So it's coming. It's part of the rationale for thinking about maybe screening newborns for a lot more things. Because there's a reason to now, right? If we catch it early, we can maybe do something before problems set in.
That's exciting.
And so newborn screening right now, it's like a lot of it's metabolic disorders where like a dietary change or something can really change outcomes quite profoundly. Now we're getting to the era where there might be a lot of rare conditions that we can fix. Now, most of them, at least initially, won't be the ones that are the kind of classic neurodevelopmental or genetic disorders associated with neurodevelopmental differences. A lot of the conditions I've been talking about, they're a different kind of genetic change that's much harder to edit that way. But some of them, but that's not true for all of them. And so it's coming. I don't think we know what it's going to mean, how many are going to work. Most of them are still in pretty early trial phases. We don't know what kind of downsides there might be. We don't know how access will be provided, especially here in the U.S. with all of our, shocking and profound inequities.
Health inequities seem to be the word that's popping
exactly
up.
what I was thinking about. There seems to be a accessibility issue potentially.
It's a huge issue. Even before we start thinking about, editing babies to make them faster and smarter and better looking. And that stuff I think is still way, way, way off in the future.
That's good.
Even when we're talking about something that seems straightforward, like curing a profound genetic disorder, the issue of inequity, the issue of access, not just to the therapy, but to the test that has to be done in time for the therapy to work. There's so many issues there to work through. And that, again, the future is open. We don't know how this will play out. And people who are involved in these fields are going to play an active role, from patients to their families and advocates through to the experts.
Drive the field forward.
And policymakers.
So Daniel, the final question you pose in your paper is, will this fetus or infant have a life worth living? And this is obviously a very big question, potentially a very emotive question, but why is it an important question to ask?
Well, it's a question that is asked. And so I think it's important to really interrogate what we mean by it. And I think part of the reason it's becoming much more of a pressing issue to look at is the rollout of what's called non-invasive prenatal screening and potentially soon non-invasive prenatal testing. And so for a long time, to do true prenatal genetic testing, you had to do something like amniocentesis, which is a little risky. It's very uncomfortable. And so most pregnancies, pregnant people didn't do it unless they were considered at high risk. With non-invasive genetic testing, you just need to take a little bit of extra blood off of another blood draw, and pregnant people are
something I've gone through myself.
A lot of blood taken.
Wow.
Yes. There's no shortage of opportunities to take a little bit of extra blood. And so now in the U.S., around half of pregnancies get this real genetic screening. And so this has gone from a very important question, but one that affected a small minority of pregnancies, to something that seems like before long it's going to be most pregnancies. And there is no answer to what makes a life worth living. And there's a huge variation in genetic disorders and what we know about genetic disorders. There are some conditions where we know it's probably going to lead to a very painful death in early childhood, if not, before. And so that's one extreme. But these tests also include things that are so mild, the vast majority of people don't know they have a genetic disorder. Things like people who have males who have an extra Y chromosome, XYY, or females with an extra X, trisomy X. Those are on those screens now too. And we really, we know those are mild, but we really don't know what they mean, again, because of ascertainment bias. And so what's happening now is that pregnant people are being told your fetus has a genetic change, genetic mutation. We can't really tell you for sure what the the range of it is. And because it's a fetus, and there's very little we can do to assess the fetus too. So we have this sort of double uncertainty.
Yeah.
We don't know if there's anything wrong yet. But you have to make a decision.
Wow.
Are you going to selectively abort?
Mm-hmm.
And so the question of what makes a life worth living, I mean, it's different for everybody.
Yeah, sure.
And at the same time, it's important to remember that when you put something on a prenatal test, it implies that selective abortion is a rational course of action, right? Mm-hmm. And so the idea that, geneticists and genetic counselors are very concerned about being non-directive, not trying to tell people what to do, just give them the information. And that's really important. Yeah. But it's also a bit of a myth because these things don't happen in a vacuum where you're given kind of information and left to make a decision. It happens in a society, in a culture, a person's individual set of values. And then again, the fact that the thing is on the test in the first place. And so it's something that everyone has to wrestle with. And part of, I think, what we need to be concerned about is that people go into prenatal genetic screening and testing not quite sure what they're going to find and what they will do. And then not even really given the sort of information they expect. They're left to make these very, very difficult decisions that are kind of clouded and uncertain. And so what makes a life worth living? I was a philosophy undergrad student, but I can't claim to have an answer to that. But I know that genetics makes us ask it. And it makes us ask it based on a very particular kind of information that comes with a lot of uncertainty. I think that's something that as a society we need to wrestle with, because if most pregnancies are subject to this is going to start changing these populations, right? And that is, even if there's no centralized force, there's no intent here, that is kind of a form of eugenics. When genetics is starting to change the population. And so it's not because people are, want to do that. It's just because you aggregate all of these decisions that are made possible through genetics over and over and over. And it's something that we aren't really talking about because we tend to let technology, to go back to your very first question, kind of get ahead of us without necessarily thinking through all of its implications.
And making decisions based on what that technology or, the information we garner from that technology tells us.
It's still so limited. Great question to ask. Look, there's so much in all of that.
There is.
I feel like we could talk for a very, very long time still. But I think, in terms of a future direction, that's always something that we're always keen and interested in. It feels like there's like 1,000 things that could be a future direction.
Definitely.
But, what would you say? Where's your work headed to from here? Like where to? What's the next
next?
Where's my work or where's the field heading?
Well, maybe both. I don't know. Like,
where are you heading, first of all? What's next for you?
So right now my main focus is, I'm thinking about some of these issues around prenatal genetic testing, but my main focus right now is thinking about what the rollout of widespread newborn genomic screening is going to look like. And I think that's something I've been studying it for 8 years or so now. And it started when I first started studying it. It was really quite a little bit of a fringe idea, but one that everyone thought was going to happen eventually. And so it was very controversial. And now, partly because of these new gene therapies and for a lot of other reasons, it feels like it's coming. And there's a consensus that we should be at least seriously investigating it. And so that to me is a potentially really transformative change if we're all doing true genomic sequencing really in the first sort of days or weeks of life. That's a huge game changer alongside these new gene therapies. It's a lot to unpack.
Lots to ponder.
Lots to do.
Daniel, you have certainly taught us a lot today and opened our eyes to a lot of, questions and conversations that I think we want to keep having, which is so important. And hopefully you will join us again at another stage on the podcast for some more of those conversations, because it's really valuable input and perspective that you've given us today. So thank you.
Yeah, and thanks again for the invitation. This has been really fun.
Oh, been absolutely wonderful. Look, I think it's something that a lot of people will be asking questions on. So I do invite a lot of the listeners who have more questions, send us an email and we can put them to you in another episode.
Yeah.
But before we finish off, we just do have one last segment, which everyone does love, and I shouldn't miss it out because when I do skip it, I do get mail about it. So let's head into the next segment, which is called Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he's been listening and he often has great questions as a result of it. So Daniel, if you can, in about 60 seconds or so, can you just summarize this body of research? And Ed, in turn, will have time for a question. Deep breath.
Need a warm-up first?
Yeah.
60 seconds. I guess what I would say is genetics can be very powerful. And it can tell us a lot. It's real. There's some social scientists who are so skeptical they think it's all kind of made up, and I'm not one of those. But we always need to keep in mind how much uncertainty comes along with it, and how much the meaning of a genetic test result depends on your family, your country, the sort of social world around you. And we also need to keep in mind as a society, as people who are engaged in research and advocacy for genetics and genetic disorders, we need to keep in mind that the future is open, right? And there's a lot of scope for good, and there's also a lot of potential pitfalls and harms. And it's going to be up to us. It's up to every parent to decide what to make of a genetic diagnosis for their child. It's up to every patient as they get older to decide what it means to them. But it's also up to us to decide what the future looks like with all of these genomic screening technologies and gene editing technologies on the horizon. And so the future is open, but just like genetics isn't determinative, the future is not determined. And it's up to us to forge a path.
Gosh, that was beautiful.
Yeah.
Wow.
Thank you. All right, Ed, over to you.
This has been an incredibly deep conversation, and I've learned a lot just by listening to it. I was going to ask a frivolous question about, blending my DNA with adamantium to become the Wolverine, but I think I'll skip that question. So, so let's not go down that path. But I guess I love the whole patient focused element of the conversation and how things and the diagnosis is not determinative. And I guess I'm kind of looking at this from a layman's perspective. I don't really understand a huge amount of human biology and health stuff, but I am into technology. And I did hear about Google and Calico Labs and their relationship with, I think it was DNA Ancestry and collecting all this information about stuff. And I guess my question is about what's the end game for where this technology is going? Is the potential of this a little bit like stem cells where they can kind of turn into anything? Like, are we looking at like eliminating disease and living longer? Is that where this technology is going to lead us?
That's a great question. It's a hard question to answer because there's so many sort of different ways in which genetics can help us think about disease. I think genetics is undoubtedly very powerful for people with rare genetic disorders. For the rest of us, it's much less clear-cut. And so when we think about, it's certainly not going to eliminate all disease, certainly in our lifetimes. And it's also important to keep in mind that in general, if we want to improve population health, right, if we want everyone to live longer and live healthier lives, genetics is really not where the action is, right? It's probably worth, really trying to help people with genetic disorders. And for a minority of the population, it can give you some pretty powerful risk information around things like breast cancer. But for most people, there's a lot of other stuff that you should be paying attention to before you start thinking about the genome. And if we're thinking about how to sort of help the population, again, live longer, healthier lives, we'd be much better off investing in things like, shelter, nutrition, the basics. The things that are sort of proven
and modifiable.
Public health standard. Yeah, exactly. Yeah. We know how to do it. Yeah. We have a lot of data. Yeah. We really know that things like public health, nutrition, education, help people live longer, healthier lives. Genetics can be incredibly powerful, but at least for a long time, it's going to be for a minority of the population. And so I think it's the right question to ask. And it's something that, because of the way that we think about genetics as all powerful, we tend to think, well, maybe if we throw all this money at genetics, we'll solve all these diseases. Genetics, I think, is going to perhaps revolutionize cancer care for many cancer patients, what's called genomic oncology. I didn't talk about that, but that's probably the other area that I think is the most exciting. Yeah. But beyond that and rare disease, if you want to invest to make us all healthier, happier, and increase our longevity, genetics is not the place to be, the basket to put all your eggs, not by a long shot.
That's great. Thank you. Good question, Ed.
Great question, Ed.
Good question.
The run continues.
Yeah, it does. Well done. Well done.
Oh, well, we could stay and talk to you all day, Daniel, but you're obviously living in the past at the moment and you have to get to bed. So we will...
I'm going to go try and kiss my daughter before she
Yes,
goes.
okay. Well, we will definitely let you go and do that. For everyone listening, the run sheet notes will be available on our website, researchworks.net. And if you want to have this recorded as part of your CPD requirements, there's also a form you can fill out so that a record is kept of this PD. But for now, we will let Daniel go and kiss his daughter goodnight. Thank you so much for joining us, Daniel, and we hope you'll join us again on another episode soon.
Yeah, thanks so much.
Yeah.
Talk to you guys all again next time.
This was a lot of fun. I'd love to come back.
Love it. Absolutely love it.
Bye, Dana.
Bye.
Bye.